Okay, and we are now live on Facebook. Hey, good morning.
Good morning.
George, glad to see you here also. So we're wrapping up here for the start as we are waiting for the hour. And it's now 9:30. I think we can start to be on time for this program. Thank you so much, dear guest speakers, for having, from your busy schedules, to having time to dedicate to this moment on the Global Hybrid Summit of the Health Data Forum. It's really good to have you all here with us in this opening session. And just to explain our viewers a little bit of the context of the Health Data Forum. So this is an initiative that started by a challenge from the Ministry of Healthcare in Portugal on doing a global event on health data in our country. And this started last year, and we were not at all planning that we could have 2020 with this pandemic. So after an initial attempt of doing a physical event in May in the beautiful venue of Cascais, we have decided to do a 28 to 30 October reprise of the online summit we had in May, hoping that we could be physically seeing each other faces in the beautiful village of Cascais, Oeiras, and we could have more time to interact, but that was also not possible. So again, we are meeting virtually, but what we are realizing now is as we meet virtually, we are finding that we are able now to do even more with virtual work, and virtual work will probably have an important role to play also on healthcare delivery. But that's the subject of today's session, empowering health and healthcare for revival and renewal. That's the subject of our Global Summit. And with me today, I have two keynote speakers that are going to do the opening address in day 2, which are Suzanne Gaunt. She's the president and CEO of the International Consortium for Health Outcomes and Measurement, well known as ICHOM. And also Dr. Charles Alessi, which is the Chief Clinical Officer of HIMSS. And later with us today, but already showing live on their videos, the guest speakers for the following CEOxCMO mashup talk. I have already on camera with us George Mathew from the US, the CMO of Americas at DXC, and also Dr. Daniel Ferreira, the Clinical Director of Hospital de Luz Digital Clinical Center, also here with us. So without further ado, and we have agreed that the program will start with the first intervention from Dr. Charles Alessi, Chief Clinical Officer of HIMSS. Charles, the floor is all yours. I'm going to stop sharing my screen now. And
great. Can you see my screen?
Yes.
Thank you. And thank you very much for the opportunity to have a conversation around what is probably one of the most important topics we're going to be wrestling with over the next few years in terms of how health and care is changing. And the vision I'm going to give you is a global vision. So really educated to a large degree by what we see in HIMSS. HIMSS is a global not-for-profit organization whose aspiration is to deliver the best of healthcare to every individual everywhere. And as a not-for-profit, we travel the world. Well, we used to. I'm now under house arrest, of course, like the rest of us. Travel the world really looking at health and care systems and assisting governments and large institutions really through their digital transformation. So let me just move ahead, because it really would be worth us thinking through around how we're going to manage this digital transformation. We've really seen a significant change over the last 20 or 30 years from a situation where evidence-based care ruled the roost. And by that, I mean really looking at populations as the unit of currency. We're now thinking much more in terms of personalized and consumer-focused approaches to this. There are significant implications to that, not least being the level of complexity that has produced in terms of the management of non-communicable diseases for clinicians, because of course, instead of one pathway, they have a multitude of pathways. And with increasing aging and multimorbidity, they have a multitude of pathways over a multitude of pathways. So the complexity is enormous. And of course, SARS-CoV-2 has done what it needed to a large degree in terms of accelerating that process. And this is a saying from Lenin, out of all people. There are decades where nothing happens, and there are weeks when decades happen. And wow, did we get to a situation where decades were happening? Because suddenly these modalities, these digital modalities are mainstream. And before, they were certainly not what one expected in every situation at all. And really, this is leading to us to consider how we're managing healthcare in a new age, which is really the age of precision. We all know what precision medicine is. We all know how targeted medicine has become. But we're also now thinking in terms of precision health, which is really the process, really through a life course of managing people with non-communicable disease or people who are prone to non-communicable disease, in other words, all of us, around trying to ensure we delay or we avoid symptomatology associated with them. And clearly, we have an enormous opportunity using digital technologies to use technology directly, using everything from nudge techniques, support, all sorts of processes to assist with the behavioral change we need around managing risk factors. And we know what the goal is. We're not really talking about longevity only. We have been relatively successful at increasing longevity really over the last 50 or 60 years. But what we haven't managed as well, perhaps, is productive, healthy aging. Really, we have sentenced people to the final few years of disability. And really, the aspiration is now to actually manage that process far better to ensure that we have as healthy and productive a life as possible. Inevitably, of course, we all have to die at some point. And I thought it would be useful to really learn from, give a sense of what's happening in some other countries. So I chose 3 countries, really, and I make an apology to the countries I didn't choose. I chose these countries because I wish to highlight something they're doing which is particularly interesting, and really to give you as rich a tapestry to see that some people are actually doing this stuff already. So we're not talking about vaporware, we're talking about reality. So let's start with Japan. Kanagawa Prefecture is a very large area to the south of Tokyo. And within that area, there have been various initiatives to try to assist citizens in managing their risk factors towards non-communicable disease, particularly towards cardiovascular disease. In other words, managing blood pressure, managing weight, managing smoking, managing alcohol, managing exertion, etc., etc. In Japan, they have a system where they have to have an annual health check. This is the whole of Japan, and this is associated with them being part of the national system for health insurance, social insurance. In Japan, every citizen has to buy social insurance from the age of 40 if they're in employment to assist with their care as they grow older. And as we need, of course, to remember, Japan is a super aging society where the number of 60-year-olds is increasing to the extent that I think in about 10 or 15 years, a third of the population will be over 60. So in Kanagawa Prefecture, they started with this process, which they call MiBio, which is neither sick nor well, whereby they institute a process whereby they get people involved and engaged, really, again, using applications and digital technology, and then assist them in changing their behaviors and use gamification associated with that as well, insofar as if they hit certain targets, they actually get reductions in the amount of social care insurance they have to pay, which clearly is a big incentive for people. What is also interesting is their use of digital biomarkers. And there's a link on the slide, which you're welcome to have a look at a later date, which really looks at mimosis and the pedometers. The mimosis is a system whereby people actually speak into their mobile phone on a regular basis, daily. And this system uses voice to be able to detect changes in affect. In other words, it starts to assist people in understanding if they're getting depression. It also starts to identify people with possible cognitive decline. This is nothing new. The Canadians are doing it as well. The Australians are doing it as well. But this is a particularly interesting example. We don't have time. I'm just going to quickly move on to the second example, which is Israel, smaller country. I chose Clalit, which is one of the health systems there. It's the biggest health system, 40% of the population. It's an insurer. It's also a provider, hospitals and primary care. And it uses something called Ideal Health. And there's a YouTube show, which is only 4 minutes long, which I suggest you look at. It's really worth looking at, whereby it's mechanized the whole process of identifying gaps in treatment using AI from electronic medical records, and then automatically referring people where they need to. Very neat, keeping physicians informed all the time, keeping primary care engaged, and stopping people falling through gaps. Really, really smart way of doing things. And clearly, this is, for a large number of us, an ideal way to move forward. And finally, Finland, which in many places is a place of wonder. Yes, it's only 5 million in terms of population. And yes, it is the place where a lot of really significant public health has taken place. We know about the Karelia project from years ago, which really started to identify high cholesterols and managing it on a population basis. There are two things here which are really interesting. One is the ability of the citizen to actually manage their health themselves. They have a system called My Cancer. Again, this is the website. I would suggest you really do look at this. There's a lot to learn. They've been on this journey for a long time, but in essence, every citizen accesses their health records, adds to their health records, and really we have a situation where we have a really activated population. And the second thing I want to highlight is their use of the secondary use of data, a significant problem in all our jurisdictions, but they have set up an independent institute called FinData to manage this and manage it very well. So what are the issues we really have to manage? Trust is the obvious one. In these countries, they've actually managed trust very well. The fact that approaches need to be tailored to the person rather than we think in terms of an app is for the whole population. No, it's not. We always think Gen Z. We need to think of all the population. And also the fact that precision health depends on really ongoing lifelong associations. This isn't about having a single intervention. This is a lifelong association. And you can't take what happens in Israel and plonk it in the middle of the Bronx in New York. It doesn't work like that. You need to understand the context of the society and the population to do that. Happy to have further conversations. I only have 10 minutes and I've kept to my time. So over to you, Suzanne.
Brilliant. Charles, thank you so much. Right, let me just try and share my slides. I cannot start the screen share while another participant is sharing. Okay,
yes,
great.
Exactly. Charles has to finish then, yes.
Apologies, I did.
No worries at all. Okay, let's just make sure everybody can see my slides. Can you see that okay?
Yeah, I can see your slides, yes, but also your notes. I'm not sure if this is the setting
Okay.
you like to show us.
Let's just try again. Let's see if we can get this to work this time. Okay, is that any better?
It's in presenter's mode.
It's still in the presenter's mode.
Oh. Okay.
But maybe you can do it from there, Suzanne.
Can you see that okay? Without the presenter's mode? Okay, I'm going to just drop a screen. I think that will help me.
Do you want me to do it from my side, Suzanne?
I think we'll give it another go now. Okay. How does that look now?
Better, much better.
Okay. Apologies.
Now it's done. Okay.
Okay. Wonderful. Sorry about that. Okay. Super. Right. Let's make a start. So thank you for the introduction. I'm Suzanne Gaunt. I'm the president and CEO at ICHOM. Also, like HIMSS, we're a not-for-profit trying to change the world of healthcare. And I've put my email address on my opening slide because one of the things I was asked to do when we talk today is tell you about how you could potentially get involved in the work that we do. So if I tell you about some of the journey that we're on and you think it could be appropriate for you, then I'd be really grateful if you reach out and get in contact. So I want to talk a little bit about, expanding on or building on from what Charles said. We're very focused on eliminating the waste in healthcare. So the changes that we're trying to make in the way we revolutionize the delivery of healthcare. We're very much focused on value-based healthcare, and we believe that it has the ability to unlock more than $2 trillion of funds that can be reinvested into making the healthcare a much better system. So through the elimination of waste, and we look at that in a number of ways. We're trying to create standardization, and through that standardization, that will allow us the ability to benchmark. So we can use our measures to determine, who's doing better or worse, where there is indifference, etc., which will enable us on the continuous learning journey. So we really need those transparent outcomes so that we can then analyze, identify best practice, change behavior on a continuous feedback loop. So that's what we're very focused at ICHOM. So in terms of how we go about doing that, so we define, at the core of what we do, we define global standards. So we have put together 39 standard sets to date, and our most recent one being COVID-19. So we very much want to help define outcomes that matter most to patients. That's where we come from in this. And we want to try to provide solutions and remove technical and operational barriers to enable access to data, facilitate the adoption of these sets, and then reporting on the metrics that matter to all the stakeholders involved: patients, providers, payers, pharma, medtech, etc. So as I mentioned at the start, we are a not-for-profit. We don't have an axe to grind. We're coming at this from a completely unbiased perspective. We're very fortunate to have worked with thousands of clinicians and patients in the development of these standard sets. And so we have a very large network of people who are engaged in the work that we're doing. And we have huge global reach. So as Paul was saying at the beginning, it's been a difficult year with COVID. So we were more than 1,200 people in Rotterdam last year. And this year we have our annual conference happening in November virtually. So quite a different year, but it's important for us to bring the community together to share best practice. And we're incredibly agile. As I said, we've created 39 standard sets now. And most of those have been published in peer-reviewed journals. So this gives you a little bit of an idea of the conditions that we're looking at, and we've started to do some overall conditions like overall adult health, pediatric health, etc. We've been established for nearly 9 years, and these are the sets that we've done over this time. In terms of implementation, we we know that more than 50,000 downloads of the standard sets have happened over time. And we're now very keen to understand those people who are implementing the standard sets, how they're getting on, because once the standard set's created, we make them freely available, and we sort of try to help people where we can when they're implementing the standard sets. But we're very keen for people to share their implementation stories, and that's what we try to bring through our conferences. So what's next for us? I talked a little bit about the standard sets, and then what we try to do from there is make people aware of them. So in addition to the conference, we also launched this year a product called ICHOM Connect, which is an online community, which we're trying to make freely available to everybody interested in implementing standard sets. But what does the future look like for ICHOM? So next year we look to introduce a machine readable version of the standard set. So at the moment you can download the PDFs, the Excels, and next year we hope that there'll be a machine readable version, which we hope will accelerate the adoption of the standard sets. And from there we are looking to implement a benchmarking platform. We very much want to allow providers to be able to enter anonymized patient records into our benchmarking platform so that they can compare that data to other providers globally. So that's what we're doing next year. So as I said, to Paul's point, he was keen for me to share a little bit about how you might get involved. So I mentioned the huge network that we have. So thousands of people have been involved in the development of the standard set. So if you're interested in joining a working group, we're looking for clinicians and patients, people who have expertise in the standard sets. We're about to start new sets in heart valve disease, in neurodevelopmental disorders, in eating disorders, and we're also developing a standard set in VTE. So perhaps that's something that you have expertise in and would be interested in. And also we're always grateful for donations to support the development of sets. Once sets are out there, we're very keen for people to join the community, get involved in ICHOM Connect, perhaps volunteer to speak at one of the conferences, share your stories, and then attend the conference, learn from other people, be part of the community. Perhaps you might get involved in a case study that we're producing to share best practice. And then from there, we go on to collect data. So although the platform's not available yet, if people are interested in being able to be a part of this, then we very much hope that we can allow people to take part in this benchmarking process. And then once that data is available, use it to improve performance. So we see it as a cycle, and we would really, really welcome anyone who's interested in being involved in this. We would love to have you a part of this. So hopefully, and that gives you a bit of an idea of what ICHOM is trying to do, how we think we can change, radically change healthcare. And we'd love to hear you get involved. So thank you so much for your time.
Thank you so much, Suzanne, and thank you so much for being so scrupulous with the time. We have plenty of time ahead of us for the discussions that are going to start. And according to the program now, we are opening our CEOxCMO mashup talk. I'm so pleased to have now also with us here Jessica Federer. Hi, Jessica. Good morning for you, early bird in where you are, right?
Good morning, yes.
A cup of coffee already. So welcome everybody, and welcome to the CEOxCMO mashup talk. Now, what I'm going to ask is a round of initial comments to this presentation, starting by order of appearance, which was George, then Jessica, then Danielle. It's so good to have here medical doctors that are so into the digital and the health data literacy. It's amazing. So what are your comments from these two presentations, George?
Thank you for letting me speak as a start. I'm looking forward to hearing what Jessica and Daniel have to say afterwards, because they're probably a lot more intelligent than what I've got to say at 5:44 or 5:54 in the morning. I know, Jess, you're on the same time. As I listen to both Suzanne and Charles, I'm encouraged because, the observations they've made from the multiple countries, as well as the efforts that Suzanne's team has been working on. They give me hope that we're all trying to go towards the same path, which is trying to improve healthcare, but really, more importantly, improve people's quality of life and the extent of their life. Typically when we talk about healthcare, I'm a allopathic internal medicine doctor here in the States. We typically jokingly call it sick care. We don't see people until they've gotten to a certain point of disease, and then we try to take care of that, what's in front of us. The preventative side, though, is typically ignored. And I use that as an analogy when I talk about the healthcare system or delivery or development over, I think in most countries. So we can debate whether the US may be kind of the worst in some cases. There are three tensions I think I see that have come up out of the points that they made. And I think there's some hope based on some of the comments they made as to how to solve those tensions. One is the concept of artificial intelligence technology versus humans. There's a huge push, at least I know on our side of the Atlantic, where people are concerned that their jobs will be replaced, or certain entire specialties. I know primary care here in the States, as an example, is under a lot of pressure to reduce costs, improve with folks that can extend their license and move up to the top of it. And that tension of replacing folks and taking their jobs away is real here. However, there are folks that have been studying this for a lot longer than me. John Naisbitt of Megatrends fame comes to mind, where he talks about the combination of high tech and high touch. With the increase in technology and use of it, there'll be an equal increase in demand of having a more personal or human touch to make that more acceptable. If that's not done in an equal measure, there will be some pushback on it. So I have hope that if we design our processes right, that high tech, high touch will take care of that tension. So that's one. The second, and I think this has kind of been brought up in other comment, I think specifically Charles, when you're talking about some of the work that's done in some of the other countries, the idea of paternalism versus collaboration. Healthcare has typically always been kind of the wizened sage on a mountain, dictating to people what they should do. And what we're finding now in the new world is that now everybody has something to bring, based on their experience with their condition. And we have to recognize that knowledge. It can't be, me doctor, you patient, I tell you what to do. It has to be much more collaborative. Charles, if you don't mind me saying, I know the big buzzword these days is patient consumerism or consumerism in healthcare. I've always had a hard time with that, just because I'm sure you have as well, Daniel, Jessica, Suzanne, because I don't think people choose to be sick. I think we need to go beyond that to more of a collaborator. Patients have agency, they have their experiences, and we have to figure out how to go to the point where we partner with them to co-create healthcare. What that term will be in the future, I don't know, but ultimately I think that's what the goal will be, and that'll take care of that tension. And then the third, I promise I'm almost done, is the idea of the incumbent business models being challenged by disruptive models that are out there. It seems that many startups, may even therapeutics that are out there, have to almost hack the system to try to find a gap or a way to get in and change healthcare. And that gap has to be bridged. Unfortunately, as many of you probably noticed, COVID-19 seems to have been an accelerator for a lot of that, because now we're forced to use some of these technologies and advances. And I believe digital transformation, I keep on using the old buzzwords, the judicious application of technology. Again, going back to the whole high tech, high touch, not just throwing tech in front of it and saying it's going to solve it. We have to redesign the system from the ground up, go for that goal of building a continuous or iterative learning system that improves the state of health for everyone, as well as their literacy, as well as their ability to make decisions. And that will ultimately take care of that idea, because now it won't be an incumbent trying to keep their business model. versus a disruptive newcomer. It'll be, we need to do this. Let's figure out how to do it together. You know, anyways, so I think I've gone over, but thank you.
Thank you so much, George. What a great insight at these hours of the morning. It's so good to have your views here from the US and bringing us closer, US and Europe and all over the world, also participants from India also watching us. We are becoming a global village. Jessica, so what are your views on what was presented by Suzanne and Charles, as well as from the comments that George already added?
Of course, thank you. Well, I'm encouraged to know our physicians are this articulate at 6 o'clock in the morning. So thank you, George, for that hope and optimism. You know, I think you put it well. The comments from Charles and Suzanne give a lot of hope that these examples of innovation and technology being used to improve health around the world are being shared. And the standardization that Suzanne is leading is critical to making sure that we're being equitable in how these advancements are being distributed. And George mentioned sick care, and I'll go a step further and say most of the world only gets survival care, you know, and then a small percent gets sick care and very few get health care. And right now we're at this interesting point where technology can be used to more equitably help and support people around the world during the time of COVID through virtual ICUs, through having their integrated tech solutions with their pulse ox to know when they need to go to the hospital. And a lot of these solutions now can be done with tech that is just in your phone. You don't need additional devices. So we're getting close to a point where technology is going to switch from being an added cost, because right now, let's face it, anything that's digital health or technology in health is adding to the cost. It's not making healthcare more accessible. It's making it much more expensive. And we need to switch away from that and get back to using tech to help more people. And as George also mentioned, the terrible destruction and devastation we're seeing from COVID-19, this, you know, hopefully the worst health event of our lifetime, and there won't be something that surpasses this. This intense level of disruption and destruction has forced healthcare companies to think differently and has switched the paradigm of the risk-averse nature. So now it's riskier for health companies and life science companies to keep doing the same thing that they were doing to avoid risk. Now it's less risky for them to use technology to get their trials started again, to connect with patients. And that risk level has really switched. And so this widespread adoption is moving us forward. And I think we're at a leapfrog moment in time where we see so many little painfully incremental steps in healthcare that takes so much energy to move a little bit forward. And now we're seeing this massive jump. And, you know, I think we'll probably go back to incremental steps after this, but the moment we're in right now is where we can leverage all of our years of experience to make sure that the technology is being used. New tech is creating new processes. You're not taking new capabilities and new technologies and retrofitting it into old processes, which is what, let's be fair, that's what everyone's been doing for the last decade. That we're really taking this opportunity to do new things that help more people with that tech. And I think that, Suzanne, that will fit really well in with, you know, how your standards are applied. You're going to have much more transparency. We're going to be able to see in real time how we're helping more people. And hopefully, Charles, that'll also help us to replicate some of these globally leading examples from countries that you mentioned, and see more of those solutions. Even today, I'm incredibly frustrated that in New York, we don't have virtual wards, virtual ICUs for patients that have COVID, yet they have it in London in the NHS, and they have it in Germany, and other countries have it already. And the results are great. The patient adherence is high. The physicians like it. It makes a lot of sense. and we don't have it. So I think that sharing of best practices is requiring us to think differently about how we're using tech. But I'll stop there, and I look forward to the comments from Daniel.
Thank you so much. I hope you're hearing me well. Thank you formally, Paul, for the invitation. Thank you all for attending. Commenting on the two keynotes that started this session, most of the more relevant aspects have already been said. We had Charles presenting us with best practices from several countries in the world. And it's always important in meetings, virtual or presential meetings, to learn from best practices. They should be shared with everybody, because if we are doing a very good practice in our institution, our country, our hospital, if we don't share it, it's not science. Science must be shared to everybody. So sharing best practice experiences are always great, but sometimes we feel that, okay, that's good for the Japanese population, it's not good for Portuguese or States population. And so then comes Suzanne and says, no, we can standardize things, we can standardize data sets, we can all collect the same data and share the same knowledge. And that's very interesting for us doctors to learn from the same databases and compare them and benchmark them. And there you are starting the benchmark part of the project of ICHOM. And I should congratulate Suzanne for the wonderful work ICHOM is doing all over the world. In Portugal, we have several institutions that are not just using, but also contributing to the data sets. So good examples, data sets, but I would like to raise another question. Is this in the best interest of the individual patient? We in Europe, you know, we have an European community with many countries. But if I cross the border to Spain, it's our neighbor, my personal data is not available there. If I go to London on holidays, if I have a road accident and I go to the hospital, they don't know my allergies, they don't know my past history. Even if the data sets could be shared, there's no easy way to share data. And I always give the example of Visa cards. With my card, the Visa card, I can purchase any item all over the world. Why can't we understand ourselves around a common data set that can share with my identity card? The Portuguese identity card has a chip on it. It could bring my relevant data set to that health data set to that card, to that chip, and it should be read all over the world as a Visa card. There are a few good examples in Europe. For instance, the Estonians are doing a very good project that are already sharing information to other European countries, but the examples are so few that we know them one by one. It should be worldwide. So I would like to hear Suzanne, Charles, and all the other faculty thoughts about sharing data sets on the individual basis, because it's happened with telemedicine in the past. In the past, telemedicine was a good solution to solve the institution's problems. We don't have a high specialist in every single hospital, so we acquired images in a remote hospital and send it to the central hospital where the imagiologists see the images. And we solved the institution's lack of manpower. But now telemedicine is driven by patient needs. It's the patients that choose the institutions that have good telemedicine, as we choose our bank, and I don't go to the bank for many years now. I do it remotely. And so could we, Suzanne, I think this question is more for you. Could we agree on a common data set that could be shared on an individual basis, so I can bring it all over the world whenever I have the need for medical assistance?
Yeah. Dano, it's a really great question, and it's a really difficult one to answer actually, because I think the concept is fantastic, and I think that we should be moving to this place. It's the 21st century, you know, we've got to catch up, right? but in practice, I think it's incredibly difficult, which is perhaps why we're as slow. If I look at the UK, I mean, just getting medical records from one part of the country to another is already a challenge, right? So never mind country to country. And in the UK and the rest of Europe, you know, we worry about GDPR and who we can share data with. And so there are many challenges there.
Excuse me, now it's even difficult with Brexit.
Well, let's not even go there. Who knows how hard things will get when Brexit really happens. So, but yes, it's not going to make things better, is it? So I think it's a brilliant challenge that we need to address. I'd love to have an answer, but I think it's a difficult one. I think it's a really, really difficult one.
It's Charles. I just wish to just answer a couple of, just make a few comments on what I've heard. One, in terms of sharing data sets, I completely agree with Suzanne. It would be wonderful to introduce Vasco da Gama to the English health system, for example, your navigator, because as an English citizen, by the way, I also have European nationality, so I sit in both camps. So half of me is Brexit and half of me isn't. So which is like the rest of humanity, I think, in England. Anyway, if we look at where we are in England, as a citizen, I can supposedly access my medical record. And what that means is I can find out my name if I forget it, my sex if I can't remember it, and my address if I'm in a taxi and can't remember what to tell the taxi driver. I can't actually access my medical record because it's still blocked. It's able, the system is able to actually show that, but the physicians aren't happy to actually share that yet. So we have an issue there. But there are places sharing data. And European Union is a good place to talk about, because there are some really interesting projects, particularly around rare diseases, which have been used to start to open this issue. And because we have, in essence, socialized healthcare systems in Europe, we're in a really good place because we don't have the taxonomy problems, which my friends in the US who are here today could talk to us for a long time about. We don't know how difficult those are. I know how bad that is. It is really difficult, because if you don't even have the basic taxonomy, let alone the clinical governance associated with managing that taxonomy, wow, interoperability isn't a technical issue. It's much bigger than that. Secondly, about the use of technology. If technology is deployed appropriately, it can be used to manage rather than cause burnout. It can be around clinical decision support along a clinical flow, not along an administrative one. And also, I just want to end up with the nature of the consultation. We've moved away from the didactic teaching type approach in medicine many years ago. We're really talking about, as you mentioned, George, people-powered health. We're talking about people being able to manage their own life course with assistance from a lifelong association. But actually, go back into your consumer comments, people are consumers. I'll tell you why, because we all have non-communicable diseases, all of us. Because actually, the fact that we only get treatment when we develop symptoms is another matter. But we all know these are lifelong conditions. So really what we're trying to engender within people is, if you manage your life course better, you will have a better and more productive, healthy life. And I think this is really quite powerful. So I think there's an awful lot we can be doing together. And the answer really is to learn from each other. That's basically it.
I'll Jess, if you don't mind, I'll throw in a couple comments about the US. You have the benefit of kind of knowing both systems fairly well. We don't have a GDPR here, as you know, so except for maybe California, that's still kind of being worked on a bit. Because we don't have that, the lack of trust has been difficult. It's made it very difficult for people to feel comfortable sharing their data. You know, obviously the Cambridge Analytica breach was kind of eye-opening for a lot of folks, but what we've had over the last 3 to 5 years of finding out that many of the hospital systems haven't been telling people they've been using their data and sharing it with Google or with Amazon without really getting transparent consent has made trust very, very difficult to come by, and by extension, data sharing. You know, Charles hinted at some of this already. Many of our healthcare delivery systems have always been local or regional in nature. So when they started developing their own taxonomies or their own governance, it was never meant to be global or national, at least intentionally. Even our electronic health record systems were intended to really be just scheduling and billing systems. They weren't designed for data sharing, not really. And getting over some of that culture change to get that to happen has been extremely difficult. Jess probably has heard this too. When Google and Apple came out with contact tracing here in the States, I want to say March or April, sign up has been minimal at best, just because people don't trust Apple and Google with their data, and that's hurting us. So until we attack some of that trust problem, I think it'll be very difficult here. The other thing, and you know, Daniel, I think you bring up a great example with your visa, right? Being able to move your money, you know, whenever you need it. When we talk about health data, people don't see their health data the same way they see their money. There's not a what's in it for me, right? At least not immediately. For folks that have a chronic condition or a terminal condition, their healthcare is part of their day-to-day all the time. So that becomes something that's very important to them that they need to manage. And they start observing who's interacting with my data, how are they using it, how is this helping me get better, what am I paying for? But for most people, healthcare is something that's transient and it happens once in a while. So they're not fully aware of what happens with their data. The closest analogy we have here are credit scores. And even that people are more aware of here, because when you apply for a home mortgage or a credit card, you need to know what your credit score is. But most people don't understand what's happening with their health data. If we create some of that short-term incentive as to what's happening with your data, because I'll tell you, and Suzanne, not to knock on value-based care, I hope you don't take offense to this. When patients are asked to participate in current value-based schemes here, there's no what's in it for me for the patient. It's just assumed that they're going to get better. Meanwhile, the patient's doing all this work to get better, but it's the physician or the hospital that gets paid for it. There's not a collaborative approach to it. So that has to change, and more of a short-term incentive has to be built before you get to a point where people will really care about, well, I know enough about my data, I'm willing to share it. That's my 2 cents. Jess?
Yeah, no, that's very thoughtfully said. So I started my pharma career in regulatory. And so I have a keen appreciation for the power that some strong regulations can wield. And I think there's a need here for a level of interoperability to be required by regulators. And I think we're seeing that. I know that's not a very popular position, so we need more regulations, but in healthcare, you take a situation like COVID, where it was really difficult to look at data just from city to city, state to state, and of course, country to country. That is a gargantuan task, and it takes way too long right now. And if regulators require certain standards to be met, well, guess what? We'll meet them. And that's always the way it's been. And frankly, that lack of incentive in the US is part of the reason we have this disjointed, fragmented, horrible EHR system we have today. You know, there was this multi-billion-dollar rollout of electronic health records in the US, but without the right standards and regulations, it led to the creation of these very big, rich businesses with proprietary approaches to your health data. So now they're billionaires off of your health data, and they paid for it with your tax dollars. And that was really a failure of regulation. And that was a failure of setting standards and enforcing standards. And again, it's not a popular position, but for something as critical as our health, you know, if you look at the standards that were set for Visa cards to be accepted in every place, there's a certain level of technology, there's a certain level of equipment, a certain level of electricity. You know, there's certain standards that had to be met in each country. And the UN and the ITU and the different UN organizations have been working to help countries to meet those standards so that they can bring in the credit cards or bring in the investment or bring in the sustainable enterprise. And we could take the same approach in healthcare, and we should.
Yeah, I agree, fully agree. I throw this challenge to you and you answered perfectly. I understand the questions about confidentialities, data safety, but I think people are getting more and more interested in sharing anonymized data. There are many initiatives, patients like me and so many others, where patients are willing, patients and not only patients, but healthy people also, are willing to share data as long as they are kept anonymized. What I was mentioning is I could carry my personal data with me, like a passport, like a credit card. And if I need it, I could allow the doctor in another country, in another hospital, in another state of my country to share that amount of data. I don't think we could or should bring with us the whole electronic health record. I don't need to know every detail of my angioplasty I did last week with so many lesions, but I should get my allergies, my current medication, my intolerance to food, whatever. And I could share this with others in a different system that is not my hospital system. It's the same in Portugal. We are a very small country. We have public and private hospitals. They don't communicate between private hospitals. The three major players don't communicate with them. So the patients sometimes have 3 health records that do not talk with themselves. And that was the challenge. We as a healthcare professionals should give that confidence George was mentioning. It's our duty to try this, I think. It's not easy. Suzanne, of course, said, and we all agree, it's not easy to make the standards, but patients are more and more prone to do PROMs, patient-related outcome measures. Probably they are also more prone to patient shared health data. As long as it is anonymized, I understand what George's saying. I'm not very keen about the idea of Apple and Google having my personal data. But sometimes we see comments that it's incredible, they have my data, and those comments are on Facebook. And Facebook collects much more data than the others. So, well, it was a challenge only, just for the matter of discussion.
Daniel, I thought there was an interoperability initiative going on in Portugal now to try to help out with some of that data sharing. Is that correct?
Sorry?
I thought there was an interoperability initiative that's going on with the government of Portugal now.
Okay. In Portugal, we have a national health system. Everybody has the right to go to the public hospital and be cared for, or public health center and being cared for. So every Portuguese citizen has the same right. The accessibility is not so easy. And so health insurances and private companies are flourishing. And we have some national health number where we can see some data. For instance, I can access all the medications the patient has been prescribed in any hospital of the country, and that's good. We have some telemedicine initiatives that were very much accelerated by the COVID crisis, as any other country in the world also. But always, I think these initiatives are meant to solve the institution problems, not the patient's problems. And I should focus on what is the best for the patient at the center. We always say that on our slides, the patient at the center of the system, but it's not always like this. Suzanne is agreeing with me.
Muito obrigado.
De nada.
I'd like to add something, because I think this is a brilliant question that it's really interesting to hear everybody's opinions on. I think the challenge is, how do we address that trust issue? Because I think, George, you're completely right. And I think we're a complete mix across the world. some people are forward thinking. You know, you wear an Apple Watch, Apple have all your data. That's great. How does that sync with what's on Fitbit and what's on, you know, what's in a hospital, and et cetera, et cetera. So how do we change people's perceptions so that they are more trusting around data? And then I guess the caveat to that is, how do we ensure that people behave in an appropriate way with data? Because, you know, is this chicken and egg? Have we actually got problems where people are abusing their positions with data, and that is resulting in the challenge of a lack of trust? And what things can we do to perhaps incentivize or motivate people to share data if we believe that it can be, you know, people can behave with it in an appropriate and an ethical way? I had a great call with a charity who were telling me how, you know, in their organization, they have all these patients who are sharing information to benefit one another, a bit like patients like me. And what they want to do is have a payback model. So when that patient data can be used by other people, they want to make sure the patient is paid so that there is an incentive. Because I think, to your point, I hear wonderful stories of PROMS capture where a hospital or you know, a primary care practice is doing really, really great things. They make it really clear. You tell us about how you're doing. You complete this PROM questionnaire, and let me show you how it's going to impact the quality of care that you get from us. And therefore, people are motivated to do it. And then in other cases, to your point, it's like, fill out this questionnaire. Why? Fill out the questionnaire. You need to, before you can see the doctor, fill out the questionnaire.
Yeah.
And then, of course, you haven't got people wanting to fill it in. You haven't got that motivation, and you have lower completion rates. But there are some really fantastic cases where, you know, when someone fills out that questionnaire and they go in to see the physician, and the physician is really sharing that data back, and the patient says, oh, wow, you know, you've read it, you know, this was valuable, it's impacting the quality of care that I'm getting from you. So is there a model where there is almost a payback to patients to get something better here?
Can I take a shot at that, or does anyone else want to?
Go for it,
George. You know, Suzanne, I've always believed that when it comes to health data in general, it's used three specific ways, right? Actuarial analysis, marketing, and sales and clinical research. Yeah. So each one of those has a market value to a degree, and it's been valued and marketed. There is actually an open trading market for that data, as you probably know, with secondary and tertiary uses of the data. What's never really been recognized is the person or the individual that generates the data. And that's not just health data, that's all data. What really needs to happen is that person who generates the data needs to be able to capture some of that financial value and use that. You know, the issue with that would be, great, so I give you money for your data. What do you do? Buy potato chips or you know, crisps or whatever, right? But what if that was turned back on itself to help pay for that person's healthcare? Yeah. I always think about the case of someone who has a rare condition that uses a specific, you know, specialty pharmaceutical that's very expensive, maybe 100 in the world. The patients like me model, which Daniel referred to, and I think it's still kind of going, is we'll take the data, but we will broker it and use it for clinical trials or research, and we'll use that to keep the lights on. I think that's a good model because it started in the mid-aughts, and no one had ever done it before. And most life sciences companies were against it because they weren't used to it. And now they have to deal with it because there's enough of a concentration of patients that have forced it into existence that now they have to deal with it. I would say that model works. I think the only other addition to it would be give some of those financial receipts back to the patients. Let them use it to pay for their care. I don't know how many stories of patients I've talked to that have been recruited for clinical trials where they will ask mid-trial, will this drug be something I can afford in the future? And the person who is giving the placebo or the the control or the experimental arm says, I don't know, or no, I don't think so. That relationship has to change, but that's a fundamental change in the business model for most life sciences companies. And you can make the same argument for providers, for insurance companies. Insurance companies may not be so thrilled about it if a group of diabetics, for example, could manage their own condition, perhaps amongst themselves, go back to them and say, as a risk pool, we cost less. So give us a better premium, give us a better rate. You don't need to spend money. We will actually reduce the cost of business in your book. Just take us on. I would imagine for a large national healthcare organization, though, like the NHS, that might be an interesting model, the community model, and then giving the tools and responsibility to that community to manage it. That's my thought.
It's Charles. There are a couple. I just wish to comment on this because we're very engaged in this place at HIMSS. Technically, of course, we're running things like the Globally Health Consortium with HL7 and you know, all the technical bits, but this basically isn't about the technical bits, because the technical bits are the technical bits. What is much more difficult is the people interacting with all of this. And I think there are a couple of truisms here. One about data and secondary use of data. It is one of the most difficult subjects. And George, I hope I don't disappoint you, but the skepticism which exists in the United States exists in all major countries in the world. It may not necessarily always be governments they're angry about, citizens, but it happens everywhere. In a place like Japan, for example, people wouldn't dream of trusting the government with any data. There have been a couple of big data breaches, but they really trust Toshiba, Sony, and all the corporations. Now, isn't that very different to what we have in other countries? In the United Kingdom, the apps have failed miserably because people don't trust the fact that data will not be misused. There's no sunset clause when the apps were introduced over COVID. They're centralized rather than decentralized. There's all sorts of issues. And I like your comments as well about people owning the data, which is why I directed people to my Cantor in Finland and FinData, which is the institute, because it took two governments before they got to the stage. Actually, governments collapsed in Finland over debate in Parliament associated with the introduction of legislation around secondary use of data. We tried to do this in England and really came a cropper with care.net data a couple of years ago. The Australians really had a hard time as well. You know, this is difficult stuff. It works very well in small places where there is that magic ingredient, trust. But that magic ingredient usually comes in homogeneously, ethnically homogeneous societies, surprisingly perhaps, because, you know, everyone's sort of the same. And everyone has sort of the same values, and it has to be small enough. If you're below 5 million, you'll probably get there. But a 60 million, a 330 million, whoa, that is some challenge, because that is really, really hard. And I think the other thing we need to consider in all of this, which we've ignored, is the issue of consent. We think of consent as being a binary blanket consent issue. Dynamic consent exists, you know. We can use that sort of process, but to do that, we need to engage with the person on a lifelong situation. It's much easier if you just have the permission and then you do what the hell you like. This is having an unaccountable system with no governance in many respects. And given the choice, I think, well, not all of us, but a lot of us would say, oh God, all this oversight, go, give me a break. I'd rather go the other way. So I think there's an awful lot of this we can do. And the more we do this together and really overcome the petty national politics, which we all live within, for the interest of the individual and the system, because we can actually make it work for both people, I think the greater chance will succeed. And we're starting to see a little bit of success. I'm not all negative.
Charles, I like your approach. I think at our company, at Huma, where I'm at, we are seeing that trust being built through the individual interaction. So, you know, Huma is a small tech company based out of London that's doing digital health work all around the world. And yet we're getting these letters from patients, really heartfelt letters that are difficult for them to send to us because, you know, they don't know it's us usually behind the tech. They have to find us. And what's at the heart of it is that this individual interaction over time builds trust. So they know they have this thing on their phone They can take a COVID severity risk assessment and see, you know, what's their risk. They can take different assessments and see what's their comorbidity risk for different diseases. They can get immediate feedback and do their monitoring for their Parkinson's or do their monitoring for different conditions through their phone. And because every time they have an engagement with that technology, they're getting information back. They're feeling empowered about their disease. They're understanding what's happening. They see the trends. They see when the physician wants to do that video chat because something's not looking right. You know, they're building that trust through every single touch point and every single experience. And, you know, in that regard, I don't know that Amazon and Google and these big tech giants in the US have earned our trust in healthcare yet. I think you really have to earn it. And coming from a big pharma company, Bayer, you know, there's like 200 different aspirins on the counter when you go to a little shop in China. But the best-selling one, if you ask every pharmacist, is the Bayer aspirin, because nobody trusts the other 199 local ones. And in Latin America, they have a saying, it's buyer's bueno. You know, like the trust that goes with the brand was earned over every single product and every single time those standards were applied consistently and those processes were applied consistently. And I think some people are expecting that trust to come too easy. You have to work for it. And you know, we're working really hard to earn it with every single touch point interaction. But I think big tech companies need to earn it if they want it. And they haven't done that yet. So I understand why people don't trust them with their health information, because they're not using that information to help people, and they're not helping individuals feel more informed or more empowered when they give that information.
Well, the debate seems to dry out a little bit here. So what should we do? I have the theme for the conference. It's the theme for this particular session in particular is how to grab this chance to renew and revive healthcare systems. How can we grab this chance to renew and revive healthcare systems? So starting from Suzanne, a round of comments on this.
Yeah, so I think if I go back to, you know, the original slide that I showed about the waste in healthcare, I think one of our biggest challenges is the cost. And so if we could eliminate some of the waste, we would have the funds to work on a number of these initiatives that we're all thinking about. And I'm not saying, you know, we can't do some of the work in parallel, but I think this is fundamental. We really need to eliminate the waste to make savings, because we need to ensure that care is available for everyone, you know, not just the privileged. And I know that, you know, it works very differently across countries. And I think, you know, we see some extremities in some regions over others, but
it seems, Suzanne, that governments are not that much, they complain that they don't have funds, but they are not that much concerns on these cost-saving initiatives that they could be making them saving huge amounts of money. It seems that there's a dormancy, right?
Yeah, so Charles and I were talking about this yesterday, about, you know, what is preventing people from making the change? If I say to you, look, if you make these changes, you're going to save this money and it will help you to reinvest in this, isn't it? Why are people hesitant? And I think the challenge, you know, we were talking specifically about the NHS. You look at a huge beast like the NHS, it's, you know, where do you start? And certainly in value-based healthcare, we can say, well, let's just start with one standard set. Let's start with one standard set in one hospital and let's prove it, and then let's do the next one and the next one, etc. But there's definitely hesitation there. And this perhaps is less of a trust issue. Maybe it's still a trust issue, but it's certainly, there's fear. I think there's fear of change. What do you think, Charles, from our conversation yesterday? Is it fear of change? Is it? Well,
no, it's more. I think it's more than that, Suzanne. I agree with you. I mean, there is an element of fear, but you know, the metrics that drive our systems are basically activity-based metrics, yeah. And that's really at the heart of a lot of the difficulties we have. We would really embrace prevention if we had not output-based metrics, but outcome-based metrics. Outcome based upon healthy productive aging, for example, be associated with interventions. And really, if we go back to the 16th century in China, that's how physicians were paid then. The people who were invited to the harvest were not the people who actually used the doctor that year because he failed them. It's the people who didn't use the doctor who invited him because he kept them well. But we've changed the system completely. So we pay when people fail us. I think, you know, changing that mindset is a big thing. And we go against a whole series of dare I call it vested interests, but in essence, it is vested interests, the big conglomerates associated with the delivery of health and care. Be they privatized or be they statal, they're still big conglomerates, and they still have an inertia within them that what they do is right because they've been doing it for a long time. And the potential to change something as radically as this is really quite difficult. There are ways you can do this slowly, but really, if you start doing this slowly, oh dear, if you signal where you're going, you're going to get people very, very worried because suddenly, you know, why do we build these edifices to sickness when we can invest a little bit of what we use in these edifices called hospitals and actually invest it elsewhere? Why do we pay 95% of the care of renal care is in dialysis? It's completely insane, considering this is a largely preventable condition. And we can spend a lot more not getting to the stage where you need dialysis. And for renal, I can talk about liver, I can talk about a whole host of issues. But the system is based upon sickness. To change it to a system based upon wellness, you need to change the metrics. And to do that, you need to be very brave because some of the physicians around this table, this virtual table, may not be at the barricades the moment that happens, but some others will be.
Let's hear about the medical doctors in this table, and also finally Jessica.
You know, being in the States, our financial incentives are very obvious. You know, because we have such a fee-for-service model, there is a tendency to kind of keep to what works. You know, our phrase is, if it ain't broke, don't fix it. And unfortunately, that's led to us to killing a lot of innovation that might help. You know, there's also the fact that there's a lot of, because of the way our system is with third parties being involved. You know, back in the day where before it was a physician and a patient or a nurse and a patient, now we have so many other pieces of the pie that have just charged more money that none of them really have an incentive, right? There's a great phrase we have where one healthcare company's inefficiency is another healthcare company's revenue line. So it's very difficult to kind of disentangle that. The opportunity to change seems to be now with COVID-19. And, you know, we've had these digital technologies that have been available for a while. We've more importantly had this sea of change where people are, you know, technology is very facile, very easy to understand. And with the way people have been able to, use user experience and digital design and whatnot, we've taken very complex topics, you know, like day trading or stock trading or financial assets, and we've gamified it, simplified it, so that, you know, I hesitate to let my son, my third grade son, at my phone because I'm afraid he'll trade stocks because he can understand it and they're very pretty colors. But it's a very complex process, but we've created this simple mask over it. I do believe we're getting to the same point with patients and their data, because they'll also demand that comprehension as to what's going on, what's happening to them. Here in the States, what's happening is much more of the cost and the expense is being pushed on to the patient. So they're becoming much more, where before there was almost a moral hazard. I don't really care because my insurance company pays for it. Now it's, oh God, I have to pay for this. And now I have to choose between paying for my healthcare or food or my rent. And it's becoming much more of a concern. So I'm hoping that that will push many of these companies to change. But I will say that, at least as an example, our hospital systems, with COVID-19 hitting and affecting a lot of our elective procedures, they're now so short on revenue that a third of the U.S. hospitals are in danger of closing. 2/3 are struggling, and they were trying to get as many fee-for-service procedures done over the last 4 to 6 months, make hay while the sun shines, because they knew that the second wave was coming. And as we've handled our part of COVID, many of our hospitals are now overwhelmed. So I do think that they're going to be forced to doing more telemedicine, more virtual health, more state laws will be, will allow for interstate licensure so that doctors can go and treat people. And I hope that that will lead to change. But there is almost an addiction, if you will, to old business models. That fear that you were talking about, Suzanne. I haven't had to change, and I'm very comfortable with it. And change is hard. So unless I'm forced to do it, or an act of God, let's call it COVID, comes in, I'm not going to do it. But there's that old phrase, adapt or die. Some won't adapt. So I'm hoping we take advantage of it to really help people, but some won't.
Okay, I think it's up to me now. In answering Paul's challenge, why isn't those technology-supported data analysis more widely approved or more widely used all over the world? I think that the main reason is because when we're talking about countries, we have a state centralized healthcare. It doesn't give you votes for the politicians that are going to decide. I don't remember in the past, before COVID, that governments are evaluated their performance by what they did or did not do preventing disease. As Charles was saying, our models are on treating disease and not rewarding wellness. I think COVID has changed even this. This week, our government was almost thrown down because the proposal for the budget next year almost was not approved. And one of the reasons was because you are not treating well the disease, but also you are not preventing well the disease. And this is a change. Now you are talking about preventing disease, a specific disease, a fearful disease, a deadly disease. Yes, we all talk about it every day. But now, today, we are also questioning how are we treating the other patients that are not COVID, non-COVID patients. We are failing on doing triage. We are not treating chronic disease. We are not doing surveys on the population to see if they are healthy or not. And governments are starting to be evaluated by this. I hear the news on the United Kingdom, and Charles and Suzanne might bring some even more data about this. They are questioning how the governments manage the NHS. Are they doing well on treating disease and preventing the disease that are preventable? So I think when we show them the data, because there's that famous phrase that in God we trust, all of us must bring data. So if we bring them the data, they don't care about our spreadsheets showing that prevention is better and you will save money in 10 years. In 10 years, they are not sure they're on the ministries. So if they are evaluated for what they are doing now, preventing disease, they will pay attention and they will invest on it. And of course, in other countries that are private or insurance-based medicine might be different. But at least in most of the European countries that have a centralized state health systems, this is ruled by the politicians that are not concerned about preventing. They are concerned about making hospitals work, but not on prevention. Even if we show them the spreadsheets showing that they will save money in the future and then they will invest that money better, that doesn't give them votes until COVID.
So this is this is the big discussion, And if you look historically, big companies making trillions of dollars off of healthcare are not suddenly going to say, let's make less money and let's have less employees and let's pay them less bonuses. So the big companies aren't going to voluntarily change. It's not going to happen. Governments are not going to go after those big rich companies because guess who's paying them? You know, our lobbyists in the US are very effective. And every representative is getting their maximum checks from the lobbyists and from the PAC groups representing these interests. So that's not going to be the route of change. So the companies won't change themselves. The governments aren't going to change them. So what is it going to be? Well, historically, the way you change big, powerful incumbents is with the new entrants rising up and growing. So the big companies aren't going to make themselves smaller, but if digital health comes in and makes a lot of their work redundant, makes it cheaper and more effective, you literally have a private sector solution where a new wave of an industry is coming in and making an old wave antiquated and outdated, and then they will have to shrink because they don't own the market share anymore. And so I think our best hope for creating change is really the digital health sector. Obviously, that's why I work in the digital health sector. I think it's a very effective mechanism for changing the entire health system, because it's literally the only mechanism we have to come in and disrupt the entire bloated, rich ecosystem that currently exists today. So, you know, as technology comes in and says, look, you don't need as many expensive stays, we can do some virtual wards. We can manage your chronic conditions better through the data and the technology in your phone. We can connect you to nurses and physicians and give you that personal human touch without all the costs that are associated, because we can triage it better and you're not waiting. You know, as technology comes in and becomes that more effective, more efficient solution, we're going to make everything else outdated, and it's going to look old-fashioned and overpriced. And so I'm hopeful that using that private sector solution, that innovation approach, we can change, sustainably change the health infrastructure. I mean, first for the US, but I hope also for the rest of the world. Paul, I think you're on mute.
Thank you so much, yes, Jessica, for this intervention. So we are 10 minutes to go. I think it's been a wonderful session already live on Facebook. So without making you, I mean, perhaps we could take a break now and have a break for the following session. And thank you all, dear guest speakers and panelists from this wonderful conversation. I had one of the most challenging job as a moderator. I practically didn't nothing because you drive the conversation yourselves. And that's when I think it's really powerful, the dialogue happening here. I'm so thankful to you. I'm thankful for our colleagues from the US to reaching out to this summit and fulfilling the promise of being a global summit. Thank you so much, Jessica and George, for being here. Thank you, Suzanne and Charles, for the care you have done on organizing yourselves for these opening presentations that are here recorded for live. Thank you so much, Daniel Ferreira, for being the EU voice in this panel, and very proud as a Portuguese for the work we are doing. And hopefully next year with the presidency of the EU, we're going to do some contributions. And by the way, George and anyone interested, later in this afternoon, we are going to have, besides the keynotes from David Novillo-Ortiz from the WHO and Lars Montelio, our research and development partner from the INL, we are going to have also a panel on the quest for the Holy Grail with a number of CIOs from different governments in the EU talking about interoperability. So George, if you're interested, stay around in the afternoon, which will be your mid-morning, I suppose. And without further ado, I would like just to share with you and thank our partners, the partners who make possible this initiative, obviously, and also guest speakers from the WHO. We are here with us today and also tomorrow. And obviously, this wonderful program we are creating here also now with the session in Portuguese. This is the moderator of the Holy Grail session. And then we're going to have also a future vision of healthcare with Rafael Grofsman. And definitely our partners that I need to thank here, Gaunt, the International Iberian Nanotechnology Laboratory, and Novartis. Very thankful for their support for allowing this conversation to happen. Also our SMEs partners, our funding partners, our event partners, including Kiko Chat, which is this platform we are using. I hope you're enjoying. And don't forget that we still have the pub and the beach, so you can have some private chats there in the pub and in the beach if you like. Try it out, it's fun. Because it's sensitive to location. So if you are in the corner of the screen, you can only speak with the ones who are close to you. So, and if you move around, you find other people to talk to. And that's an innovation from Kiko, definitely. We are 5 minutes to start. Our venue partners and of course, last but not least, also our supporters, the network of supporters, and IMS. We are really proud to be a partner innovation exchange of the HIMSS. And thank you so much, Charles, for the contributions. And also Annette, I think Annette is also in this call, Digital Health Portugal and Kukabaytech, our sponsor partner. So thank you so much, dear friends. And let's take a break now for the next session that will start in 5 minutes. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye. Bye-bye. Hola, Augusto. Augusto, buenos días.